Hi, I'm Dr. Dan Driscoll. I'm a medical geneticist at the University of Florida College of Medicine and also on the Clinical and Scientific Advisory Board for IPWSO. And I've been asked to talk about the genetics of Prader-Willi syndrome. So what does a medical geneticist do, first of all? Well, we're consulted when there's an infant or a child who appears to have a syndromic condition. For Prader-Willi syndrome, this typically occurs in the neonatal intensive care unit. There are babies with poor muscle tone, hypotonic, floppy, and feeding difficulties. This is a typical presentation for babies. We then make suggestions for particular genetic testing based on what we see on the physical exam. We follow up on the genetic testing, and then we do sit down with the families, do genetic counseling, and go over recurrence risks. And then we follow the patients in clinic that have a rare genetic diagnosis, since not many people are experts in rare conditions except for medical geneticists. And then we make referrals as necessary to various other specialties like pediatric endocrinology and pulmonary, etc. So the goals of this talk is focused on families with a recent diagnosis of Prader-Willi syndrome. I'm going to review how Prader-Willi syndrome occurs, and then the genetic testing we do for Prader-Willi syndrome. What's the recurrence risk for families with a child with Prader-Willi syndrome, and what information should a family expect to receive from a geneticist? Now, you're forewarned, the genetics of Prader-Willi syndrome are complicated, even for physicians, and even for medical geneticists not that familiar with Prader-Willi syndrome. So there's a good detailed review of Prader-Willi syndrome in the online genetic resource called Gene Reviews if you need more information. All you have to do is write Prader-Willi syndrome Gene Reviews, and you should be able to find it. So, how does Prader-Willi syndrome occur? Well, first of all, Prader-Willi syndrome is an imprinted condition in a small region of chromosome 15. So what's imprinting? Imprinting is the differential gene expression in a particular region depending upon whether the inheritance of that genetic material is from the mother or the father, maternal versus paternal. There are maybe a couple of hundred imprinted genes in our genome, and it makes a difference which parent those genes come from. The rest of the 20,000 genes don't care whether they come from mom or dad, but there are rare genes, and in the Prader-Willi syndrome, this is very important. So in this chromosomal region, some genes only expressed from the father, other only expressed from the mother. In Prader-Willi syndrome, the key thing is a lack of a paternal, a contribution from the father in this region. There's a much different syndrome called Angelman syndrome that also occurs as a result of a defect in this region, but it comes from the mother's chromosome. So it's important to identify the source of the absence. And most cases are new mutations, which means they happen spontaneously in gametogenesis, which is the making of sperm and egg. In other words, neither parent typically has Angelman or Prader-Willi or the defect. And this means there's a low recurrence for most of the families. Now, there's an exceptional case, a few cases with the imprinting center deletion, and I'll talk more about that. Most cases are spontaneous mutations, and the parents did nothing wrong. So the Prader-Willi syndrome deletion region is shown in this slide, and you can compare the chromosome on the left to the chromosome on the right, and you can see this is a very small region under the microscope. However, if you look at the DNA level, this is very complicated, and you can see the genes listed in blue here are only expressed coming from the father, while the genes labeled in orange are only expressed coming from the mother. The genes labeled in green don't care whether they come from the mother or father. Also on this slide, it shows you a type 2 deletion and a type 1, which is longer. Now, those account for the vast majority of deletions in Prader-Willi syndrome. There are rare exceptions with a somewhat smaller deletion, which may give milder features, or a much larger deletion, which will give you a much more severe phenotype. So it's important to find out the deletion size. Now, again, most are type 1 or type 2 have an extremely low recurrence risk in families. In other words, the chance to happen again in the family. There are 3 main molecular classes or genetic types of Prader-Willi syndrome. There is the paternal deletion, which accounts for 60 to 70%. There's maternal uniparental disomy, meaning that there's 2 normal chromosome appearing 15s, but they happen to be both from the mother and none from the father. So there's an absence of the key paternal region. And then there's imprinting defect, where there's a small little defect in the imprinting center that controls this 5 to 6 million base pair region. And we'll talk a bit more. Now, all these genetic types can be picked up by DNA methylation analysis. That's very key. My lab and others worked out this technique back in the 1990s, and it's the workhorse technique to diagnose Prader-Willi syndrome. Now, DNA methylation is 99% sensitive and 99% specific, so it's a very good test. However, it will not pick up the genetic type. It cannot distinguish between deletions, uniparental disomies, or imprinting defects. So you need additional testing once you've got the diagnosis of Prader-Willi syndrome through methylation. Then you need to do some additional genetic testing. So what's the benefit of early genetic diagnosis? I've been in this field for over 40 years, and remarkable progress, particularly in genetic testing. The robust genetic testing was developed in the 1990s, have led to a significantly earlier diagnosis and treatment. There's increased awareness now by clinicians and advocacy groups like IPWSO, IPWSO, USA, FPWR, etc. And so the average age of diagnosis for many young children is now less than 1 month of age in countries that have sophisticated genetic testing. Versus back when I was in my training in the 1970s and 1980s, the average age was 8 to 12 years of age. So big progress. This early diagnosis enables earlier counseling, anticipatory guidance, behavior modification and treatments, as well as the correct diagnosis. Why does my child have these features? What did I do? Did I do anything wrong? Can it be inherited? The correct diagnosis in genetics is very important for the reasons I just stated. So how do we establish the diagnosis? We start with DNA methylation analysis. Typically, it'll diagnose over 99%. I also start with a chromosomal microarrays, which is also called an oligo SNP array. This will pick up the deletion class and the size of the deletion. Microdeletion, it'll also pick up microdeletions that include the tiny imprinting center and a very important gene called SNOD116. And it'll pick up about 70% of the uniparental disomies, but not 100%. So it's important to know the genetic type, and it usually takes 2 tests, usually DNA methylation analysis and chromosomal microarray. FISH will confirm a deletion if present, but it's an old test that we used in the 90s. a little bit in the early 2000s, but it's really not used very much. It will not reveal the size of the deletion. It'll tell you whether a deletion's there or not, but it won't tell you what size, and it won't tell you the parental origin. Did it come from mom or dad? It won't pick up uniparental disomy, won't pick up imprinting center deletions. And so the next slide shows a picture of what DNA methylation analysis looks like. A lot of you have heard about methylation-specific PCR, but here's a visual concept. In the key region for Prader-Willi, a gene called SNRPN is methylated on the mother's chromosome. There's DNA methylation on the DNA, and it's unmethylated on the father's chromosome. And if it's unmethylated, the gene can be expressed. If the gene is methylated, it won't. So you can see in this slide, at the top, the maternal band is methylated and the paternal is unmethylated. So then Angelman syndrome only have the unmethylated paternal, and Prader-Willi syndrome only have the methylated maternal contribution. And so you can see this is a very easy, straightforward test to do. And visually, that's what it looks like. So just to quickly review the Prader-Willi syndrome diagnostic testing. DNA methylation we've talked about. Methylation-specific PCR is the most frequently used DNA methylation test. There's another test that's even better called methylation-specific PCR coupled with MLPA. And what that does is looks at methylation at 5 or 6 different sites rather than just one site. So you have the testimony of 6 sites for the diagnosis, plus it gives you some dosing information. Again, DNA methylation picks up 99%, but doesn't identify the genetic type. We've talked about chromosomal microarray. Important to know the deletion size. Some patients have a much larger deletion, and this is important to know. And it'll pick up the little tiny imprinting center deletions, but it won't pick up a class we'll talk a little bit more about, imprinting defect epimutations, and it'll pick up 70% of the interparental disomies. Now, we have another test called UPD testing or DNA polymorphism testing. Sometimes what we need to do is look at the DNA from both parents and the child, what we call a genetics program, to track the inheritance. This is needed in some cases, again, and it's called a trio, since you need the child and the 2 parents. And this is needed to distinguish some types of uniparental disomy. Other tests that look at the whole genome, some clinicians don't say, I've got this baby or this child, I don't know what's going on. So they just blast the whole genome. And then one test is called whole exome sequencing. And that looks at all the express regions in the genome, which are only about 5% of the genome. And again, in this case, you need the trio, the parents and the patient. So sometimes clinicians, they don't know what's going on, they blast the genome, and then Prader-Willi pops up. And another test is whole genome sequencing, when you're sequencing all 6 billion base pairs of DNA. Again, you need the parents and the child. But again, usually that's when physicians are unclear what's going on. If you have a sense of what's going on and that this is Prader-Willi, do the DNA methylation analysis and chromosomal microarray. So recurrence risk depends upon the cause. In deletions, most are sporadic, and the recurrence risk, we quote families, is less than 1%. If there's a translocation in one of the parents, then the risk is increased. And just to point out, some women with Prader-Willi syndrome have gotten pregnant. They have decreased fertility, but there are some women that have gotten pregnant. And if a woman with Prader-Willi syndrome has Prader-Willi by deletion, there's a 50% chance of her passing on that deletion, and she will have an Angelman child in that case because the missing material is coming from the mother. Uniparental disomy cases mostly are sporadic, but the risk increases with maternal age, similar to what happens with Down syndrome. So risk for women over 40 years of age has been approximated to be 1 out of 3,400 for Prader-Willi syndrome. And again, in Down syndrome, the risk goes up. Whereas the population prevalence and incidence is usually about 1 out of 10,000 to 1 out of 20,000 with Prader-Willi syndrome, but it increases with the older the woman gets. And again, but overall, it's less than 1% recurrence risk. Imprinting defect, the third genetic type or class, most are what we call epigenetics, that are spontaneous. In passing the sperm and egg on, parents are supposed to erase their imprint and then the imprint that they got from their mom and dad, and then put the maternal specific imprint on or the paternal. Sometimes that gets screwed up, and the imprint from the father on his mother's chromosome doesn't get erased. These are typically sporadic. However, 10 to 15% of the imprinting defect class are due to a deletion in the control center that controls this region. And if the father's a silent carrier, then there's a 50% risk that he would have another child with Prader-Willi syndrome. So again, this is the reason that we need to know the genetic type. I'll mention prenatal diagnosis is possible for all causes. The DNA methylation will pick up all three molecular types with amniocentesis. Now, most women now are not getting amniocentesis. They're getting what's called non-invasive prenatal screening from the maternal blood. There's some fetal DNA floating in mom's blood while she's pregnant. These non-invasive prenatal screening tests are good for picking up Down syndrome and some other big chromosomal abnormalities. These little micro deletions, they have a very high false positive rate. So if you elect to have the deletion testing by non-invasive prenatal screening, what we call NIPS, then and it comes back positive, you need to follow that up with an amniocentesis as the gold standard test. These are called screening tests for a reason. So imprinting defect class, I just want to emphasize that more. That's the class you really have to know if there's an imprinting center deletion to know the recurrence risk. And again, it's only 10 to 15% of the imprinting defect class. And the imprinting defect class as a whole is only 2 to 5%. So we're only talking about a small minority of individuals with Prader-Willi with the imprinting center deletion. But we need to know that to accurately tell families recurrence risk. So I've been asked to talk a little bit about genotype-phenotype correlation. In other words, what are the differences in clinical features between the various genetic types? Well, as a whole, the differences are subtle. They're not huge, but no matter whether you have deletion, UPD, or imprinting defect, you have most of the same features of Prader-Willi syndrome. I will say, in patients with a uniparental disomy, there's usually a slightly higher verbal IQ as an average. And again, there's wide ranges in all these classes and overlap. There's also a greater frequency of autistic spectrum features with UPD and a greater frequency of psychosis, usually starting in the teen and adult years. So knowing the genetic class helps you know what to look out for. More common in the deletion class is hypopigmentation. They typically have lighter pigmentation than their siblings, and that's because there's typically a deletion of a pigment gene in this region, that if you lose both copies of that pigment gene, you're an albino. But in Prader-Willi deletion cases, you're only missing one gene, so you have a lighter pigmentation. The facial features of Prader-Willi syndrome are more pronounced in the deletion, the bitemporal narrowing. And seizures are a bit more common in deletion, and they have a little bit more skill with jigsaw puzzles than the other types. So, summary key points. Vast majority of cases are random sporadic events. Importantly, the parents did nothing wrong. These are rare mutations that happen in making sperm and egg. And by the way, mutations are happening all over the genome and other genes. There's rare cases of imprinting center deletions where it can occur in a family and you need to know the genetic type. Genetic counseling is very important, and you should follow up periodically in medical genetics, since geneticists tend to keep up with the latest and greatest, and if there's other testing, and they're very good at knowing which specialties to refer to. So thank you very much for listening. I hope that was somewhat informative, and again, thank you.